morning to everyone. Welcome to this joint webinar from Comfortage and Laurel. My name is Sara Canella. I'm Digital Health Facilitator for ETEL. And I'm here representing the two projects, since I'm involved in the Laurel project, which is an Horizon Europe initiative that is developing actionable policies for integrating long-term care. And I am also involved in the Comfortage project for Dementia and Frailty. And the aim of this webinar was born since we found different challenges between the two projects, and in particular about social and health care initiatives. We have seen that there is a lack of social and health data integration, sharing, and there is a real need of integrated care frameworks. So that's why we would like to address these topics during this webinar. With me, we have Luc Nicolas, who is involved in the Comfortage project. And I would like to ask him to present himself and introduce a little bit the objectives also of this webinar. So, Luc.
Thank you very much, Sarah, and good morning, everybody. So, indeed, this the fourth webinar they're organizing in the context of the series of webinar around dementia and frailty in Comfortage, and today trying to connect social care with the input from Laurel in particular. But I would like to stress a few points. In the past, when we were thinking about connecting social and clinical care, we were mostly looking at care. Today, the main challenge goes beyond that. We need to change a bit our perspective when we look at prevention, which needs to be developed maybe in a different way with different kind of actors. Our health systems are really under very high pressure, and we need to mobilize all the actors of the value chain, the social actors, the clinical actors, but maybe also other kind of actors. So the roles in the system need to change, and everybody needs to take a share and a bigger share, and a shared responsibility in trying to detect as quick as possible issues, problems, and indeed have a holistic view to how we can enhance better prevention. So before we are engaged in very heavy care patterns. So today we will be looking at indeed services like in the past and how to better integrate those services, but also looking at the opportunities of digital health and data. How can data help us, and how can we all provide the data which can help us to take the right decision and organize the services in a very different way than it is done in the past. So it's about roles, it's about data, and it's about new actors coming in the system to support this better integration. So that's my few words of introduction today, and we are now very happy to hear the specific inputs of our speakers, Sarah.
Yes, thank you very much, Luc. So we have now three main presentations with 4 speakers. The first one is Marco Albertini from the University of Bologna, who will present the initiative of AGIT. So please, Marco.
Hi everybody, and thank you for inviting me, and thank you for being here this morning, Friday morning. So I'm gonna share my slides. Let's hope everything is working fine. So I have to share the screen. So let me know if you can hear me and see me correctly.
Yes, perfect.
That's okay.
Thank you.
Very well. Okay, so as Sarah has mentioned, what I'm presenting today is a work conducted within the framework of a project. It's a large project called AGIT. AGIT is one of these projects financed with the Next Generation EU funds coming to Italy, and a small part of that went to the university and research area and not railroads for once. The good thing is that it forced us to address some challenges. Okay, there were many of these project finance, 15, and each of them was kind of searching for collaborating between different universities, but also between different actors. So not profit, companies, private companies, institutions, statistical institutions, and so on, to address some of the challenges facing Italy and more general European societies. And one of these challenges was identified in the increasing population aging. And within this Age IT project, which was, as you probably are aware of the EU terminology, so was divided in 10 different parts, each of them being called spokes. And I was the coordinator, the national coordinator. I mean, I'm still, the project is ending in a few months, of a spoke which was devoted to focusing on long-term care. So the challenge of providing long-term care in a sustainable way in a context of aging societies. So, okay, let me check if this is going as it should be. Can you see the slides moving? Of course.
Yes,
Good.
yes.
So what is the challenge of aging? So possibly many of you already know that. So let me go very quick on the first slides, okay? So the first slides are about why is aging a challenge, but it's also an opportunity. So we shouldn't forget the opportunity side, okay? We cannot focus only on the bleak side of the story. So we do have aging from the top, and people tend to forget we also have aging from the bottom, which means that having low fertility, it means that we are increasingly facing huge challenges in finding both formal and informal caregivers for people in later life having long-term care needs. So one of the we focus on different part of this project that we'll show very shortly. And a part of the project was also focused a lot on Alzheimer and dementia. In Italy, there is an estimated number of 2 million people with early stages of dementia or later stages of dementia and Alzheimer. And that means that 2 million people, you probably need to multiply by 3 at least for when you consider also the involvement of informal caregivers, and not to speak about the formal care and healthcare sector. So the point that we have aging from the bottom and not just aging from the top leads us to, and the actual kind of solutions that are in place, led us that a big part of our job was to convince policymakers, but also people from NGO and so on, to say, look, it is important that we increase resources, but it's possibly not even close to be enough. We need a massive investment in innovating, in doing things in a different way, just because aging from the bottom, it means we simply don't have the people to do often enough people to fulfill the needs if we keep meeting these needs with the same strategies. So most of policy intervention and instruments so far in Italy, I'm talking about the Italian case, of course, so I apologize if this is kind of old for people from other countries. So, but basically most of the research is focused on care receivers, medical intervention, labor or capital intensive intervention. We have met an impressive number of pilot projects that are fantastic. And then you ask, so how many people you have in this fantastic project? 42. Okay, so what is your target population? I don't know, 400,000 people. Well, that's not even close to be enough. You know, it's a fantastic project, but it's very intense, but it touches very, very few people. So we also are moving into a context of what we call a family by default approach, which means that the welfare state invests a lot in cash for care. There is the usual fragmentations that we find in many countries. That means that we have healthcare policy. We have finance, transfers and some support like paid leaves that are legislated at the national level. Then we have healthcare, which is conducted at the regional level. And then we have social services, which are at the municipality level. And these different sectors and the different institutional levels have some difficulties in connecting, and often the informal care receivers are there and they need to connect all the dots while also taking care of the person they cherish about, they love. Okay, so that's kind of well, that's challenging, isn't it? So we change a little bit this focus on what wasn't done so much in Italy so far. So was focusing on the caregivers' well-being, with the idea that by increasing the well-being of the caregivers and investing in the caregivers, we might actually increase the care recipients' well-being even more of sometimes, and especially for Alzheimer and dementia, than the direct investment into this into older people with Alzheimer and dementia. What is important, and I think that also Sarah, directed me in this, into these directions, like focus a lot on this, which apparently might be useful today to let you know that we have, since the beginning, integrated very different approaches. So we are sociologists, psychologists, people in educational science, medical sciences, and policy approaches. But we are not just academics, and that was a huge advantage. We are not just academics. We are not there just to having the next article published. We actually don't care too much about that. We are lucky to be in this position. Okay, so we wanted to test large-scale technological assisted intervention. So kind of, okay, let's focus, instead of having intensive thing, let's focus on caregivers, having interventions that, or instruments that are not that expensive. They are sustainable socially and economically, and they can address maybe little of the needs, but of many people's, not just 42. Okay, so okay, so how we do that? Well, different actions. I will go through, okay, I don't have a clock, which is bad because I know.
Yes,
so Sarah,
fact,
let me know how many minutes I have left.
Very few, like 3 minutes.
Geez, okay, I have to rush. So
yes,
we have these actions: mapping, monitoring, mapping at the social and geographical level, monitoring individual caregivers, training and informing caregivers, supporting policymaking, and increasing social awareness. And the materials will be circulated. So if I'm going too fast, then you can catch up then, I guess, with the slides. Okay, so mapping, what does it mean? We have constructed indexes at the local level that actually can help municipalities to identify those areas of the countries who are at risk of facing insufficient formal and informal care available vis-a-vis the population composition. So the red points are our index is saying that the services are too distant, and there is far too many imbalance between people aged between 60 and 85 or 75 plus, and younger people who can provide support. But we also map this at the economic level, at the social level. So on the right, you can see how services are used differently by people in different income in different parts of the income distribution. And you can see so this is mapping, so helping also policymaker to identify where is the highest risk. But then we use technology and integration of software and web app and surveys to monitor caregivers' well-being, psychological, physical. We use sensors, but we use also questionnaires, and we have found, for example, that the social withdrawal of individuals, I will go quickly, but the social withdrawal of caregivers, especially in the case of dementia and Alzheimer, well, you don't need to wait them to show depression symptoms or, problem with sleeps or physical problems. Social withdrawal is already conductive to these problems, So it's a very early stage, and you can do that with a questionnaire. And so integrating social perspective into kind of medical diagnosis. We also develop educational website, but also a chatbot. Chatbots are already there. Why not using ChatGPT or other chatbots? Well, because in ChatGPT you can find that if you I don't know, if you take paracetamol, you develop autism. Well, we don't want these kind of things. We want to have the chatbot relying on reliable information. And so we built our own chatbot for caregivers of people with dementia and Alzheimer. And we want to integrate local specific information in this chatbot so that people can know also the NGOs and so on that are available in the area where they live. We also use this bunch of data. So sorry, Sarah, I know I'm overshooting, so I will
No problem.
even increase my speed. So we wanted to support small municipalities that have very little means and also human capital to program their own planning. Okay, and so we use basically sensors, but we also use drones and data generated by sensors attached to people to study how people move in small villages, very aged, okay, in small towns, to help mayors to locate the services so that we increase the walkability and we decrease the need of assisting these people moving around to go to the pharmacy or to the doctors and so on and so forth. And so that was possible only integrating social and physiological and institutional data. We also want to increase awareness. Part of the story is that caregivers are not visible in the public discourse. So what is more compelling, unfortunately, is not just data. What is more compelling for policymakers and people and the common people that then support policies or not are stories. And what about the stories, the biographies of caregivers? And we thought that caregivers often are kind of, withdraw from the society, they are invisible. So let's make them visible. We have constructed a website where they can go there. They can ask us to go and interview them through reconstructing their biographies of care and life. Also giving the nice things emerging from caregiving, the things that I have learned, not just at the dark side, okay? But also people can just use their mobile phone and do the interview themselves. And we are collecting a lot of audios and videos, very long interviews that will be made available for the scientific communities, but most importantly for media and policymakers. So giving a voice and a face to informal caregiver. We think this is important. It's not just for having headlines in the journals. It's the first step to have things changes in the policy making, we think. And that's it. Sorry.
Thank you. Thank you, Marco. Thank you very much for this very interesting presentation. There is a question in the chat if you want to address it in the chat, or we can come back later. Meanwhile, I will like to give the floor to Jodie Illen from ARIA, from Australia. So thank you very much, Jodie, to be here. And she will present empowering data literacy and capability to drive quality. So Jodie, the floor is yours.
Okay, great. Thank you. Thank you so much for inviting me to present today. Quick time frame, so I'm going to rush through. I've put a lot more information in the slides than I'll probably talk to, but there are things people, if you want to contact me afterwards and we can chat through them, that's fine. I'm based in Adelaide, South Australia. My background is clinical pharmacist. So I trained as a pharmacist. I worked in gerontology in both acute care and community care, and researcher, pharmacoepidemiologist. And I had the absolute honour of assisting both my father and stepfather through their late years of life and their palliative care. So I've got a bit of lived experience as well. Okay, so what we do in Australia is we want to always acknowledge the Indigenous people, one of the oldest cultures in the world. And we acknowledge the Kaurna people of the Adelaide Plains, which is where I'm from. They are the traditional custodians whose ancestral lands we gather on today. We pay our respects to elders past and present, and we value their ongoing connection to land and cultural beliefs. So I just want to give you a quick overview of ARIA. So ARIA is the Aged Care Research and Industry Innovation Australia. It was established in 2021, totally government funded. The two main things are growth and translation. So we wanted to increase capacity to adopt products and technologies for aged care delivery. We want to create adaptive spaces to enable innovation to thrive. As you all know, in the aged care space, it's changing so quickly. And there's so much legislation and different things and digital enhancements and so much going on. We wanted to be there to support our aged care providers in Australia to, adopt any kind of innovative therapies and make sure they can provide best care for their residents and also home care people. And a lot of what we do is adoption of evidence-based best practice across aged care. We provide information, summaries, education, and we also support adoption of innovation to solve wicked problems. So we sit between academia and real world aged care providers. We bridge that gap. We hope to bridge the gap. Okay, so when we're looking at the Aged Care Collaborative, which is a really central part of what ARIA does, we look at, we provide different grants to different people. So previously it was all traditional grants where we just, ask for expressions of interest, give people the money. It was a partnership with a provider and an academic institution. They go do the work and come back. And then the feedback was, we just don't know how to grapple with sustainability and how's this going to work, because kind of the academic side took over things and then it couldn't be sustained in the real world aged care provider environment. So then these two flagships were set up, and I'm mainly involved with flagship 2, and this is what I will talk to you about today. And it was the whole topic was taken from extreme and extensive engagement with previous grant recipients, but also the Australian government. And it was around, okay, we've got this whole environment of data. Do people know what to do with it? So flagship 2 is a $1 million project, and it's about empowering data literacy and capability to drive quality of care in the aged care sector. And just to give you a little bit of an idea about what's happening in Australia, so you can set the context, the Australian aged care sector is extremely dynamic, it's forever changing. We had a Royal Commission into the aged care quality and safety with 148 recommendations. We've now got requirements of 24/7 on-site registered nurse for long-term care, 200 care minutes per resident per day per long-term care. This is all data that has to be captured. We have over 10 mandatory quality indicators that are reported quarterly, and I'll get to that a bit later. Serious incident reports, a new aged care hack, strengthened standards, new code of conduct for aged care. It's just a huge environment and it's changing all the time. And our aged care providers are very vulnerable and really trying to keep up with all this. But of course, the goal is to make sure that we have improvements, that we have person-centered care, that we have high quality care, and we have flexibility and choice in the aged care sector. So over this period, since the Royal Commission started in 2018, there has been an enormous growth in data being captured by aged care providers. And what are they going to do with it? What do we do with this data? How do we make sure we're using it in the right way? So flagship 2, coming back to empowering data literacy and capability to drive quality of care. So we know that aged care providers invest significant resources in capturing data. However, they have reported to us and externally and to the government that data is underutilised. They have so much data, they don't know what to do with it. Data sources are fragmented. They're sitting in different silos, like who's doing this, who's doing that. There's national data, local data, state data. And there are very few resources to support data literacy and data maturity. When you think about the aged care workforce, there's very few people on the ground that would have any formal skills in how to appropriately collect data, manage data, secure data, and then report. And so this was identified by the Royal Commission and also by the Aged Care Data and Digital Strategy, that it's really important to get this right so that we can manage and deliver high quality care. We want to use data in the best way we can to make sure that Australians receiving any aged care service have the best quality of care. So this is what Flagship 2 wanted to do. We wanted to empower aged care providers with the knowledge and capability to leverage existing data sources to increase quality of care. So we sent out expression of interest. We approved 8 aged care providers, 2 support at home. So 6 were residential aged care providers, which is known as long-term care in many settings. And then support at home is aged care services provided in a person's home. So we have that kind of hierarchy in Australia. Most of the aged care providers were urban locations, and we had a mix of private, not-for-profit, large and small. This is one of the testaments from one of the providers who ended up participating, because they understand that data is such an important place in what they're doing, and they just want to make informed decisions and make sure that their team can deliver best practice. So what we decided as a team was we would choose a mandatory pressure injury data. So in Australia, we have 14 mandatory quality indicators that are reported every 3 months through a government portal. And there are guidelines to them, but to be honest, if you read them, you would be looking at, well, I could report that anyway. It's quite challenging. So we just used pressure injury data as a vehicle for this project, but the learnings are applicable to any of the quality indicators, or basically any quality project you want to do, because it's around making sure your data is right, making sure you understand your data, and making sure you make that work for you. I just used a little speed car here. We had 12 months for this project. That's all we were funded for. So it didn't allow us a lot of academic rigour, but we really did invest as much time as we could. So in the first phase 1 of the project, which was 2 months, we asked and designed and did a survey on digital and data maturity at an organisation level. And then in phase 4, which will happen at the end of June this year, we'll reevaluate that. So we'll compare what they said their data and digital maturity was at the beginning of the project before we did anything, and then afterwards. Oh, okay. So our digital data maturity domains are not dissimilar to ones that ETEL have used in their recent online survey, very much informed by, oh, sorry, did I miss? Yes, I missed a slide. There you go, sorry. Tool developers and distribution. So on the left-hand side of the screen, there is an example of what we did was we distributed a paper survey that was, well, paper, Word document, that was informed by industry tools, research, subject matter experts, and we had our team internally validate that. And then we asked them, to do this as a team effort, because it's, digital and data maturity is a team effort. It's not just one person doing it. Hopefully it's not. So then we asked them to do that as a team and gave them about a month to do it. And then we gave them a Qualtrics survey, which was exactly the same questions that they could put in as their final answers. The purpose of this survey, as we communicated to the providers, was to get a sense of the current state of where they're at, and also to help us to tailor the education that we were going to do over the next 6 months. We also wanted to know how to demonstrate how learnings throughout the next 6 months would impact on their quality of care and achieving data and digital maturity insights. These are the domains, looking at the time. So they're very standard domains, and there were 2 or 3 questions per domain, basically, and they were like, how far along are you on this spectrum? Are you fully implemented, not implemented at all? It was those kinds of Leichhardt questions, so nothing too challenging. However, we did ask we asked a lot of free text questions, And there's a lot of richness in that, which we're still analysing. But we did ask at the end, where do you want to be? Like, what are your future goals? What's stopping you from getting there? And what do you think the government should do? So we did a lot of that kind of, you know, qualitative stuff at the end. So now I'm just going to quickly share some insights. As I said, we're in the process of finalising results, so I really have cherry-picked results. Basically, what I thought was more relevant for this audience. So in terms of governance, they all reported they have really good governance. However, only 50% had a data steward to oversee data management and quality. So that would be a recommendation for us to all aged care providers to make sure they actually have a data steward that is assigned to making sure data is good, managed well, and is of high quality. 63% referenced electronic systems as central to clinical governance and reporting. Well, everybody, you know, in Australia, we've moved from paper-based since the Royal Commission. Most people have moved from paper-based to electronic for everything. And that even includes medicines charting, medical, everything. And it's been a huge shift for people working in that area to take that on. So when we looked at infrastructure and tools, about 2/3 said they have some extent of integration. 50% of sites have partial integration with government platforms, and that's a huge issue because of our mandatory indicator reporting. But also we have healthcare records and My Health Australia and things like that are public health primary care databases that people can't access. And you need a password, and you need to be registered, and you need to do this, and there's only one person at the site that does that, and they're off today. So there's a lot of challenges around that. System integration continues to be a significant barrier, and this is partly due to inconsistent data definitions across systems, access limitations and resource constraints. So a quote from one of our participants is that integrated assessment tool content cannot be transferred. It can only be accessed as a PDF. So there's a lot of blockers in the system of trying to get things to integrate, which is, I think, of significance to this group. Data quality. It was really interesting. They said the data quality was quite good in the survey. And then you'll see some things at the end. We did this as baseline, and then we worked with them for 6 months. And what we found over 6 months was their data quality was really poor. And they realised it was really poor over those 6 months. So the survey results did not reflect the reality of the situation. And I think that's a really important point that I'll bring up later on. Analytics
sorry, Jodie, you have sorry to interrupt you. You have 1 minute more.
Great, I've only got 2 more slides. Great. All sites have standardised reporting implemented to fully implemented, which is great. 50% say they use predictive analytics or machine learning for care planning. I'm not quite sure I believe that one after working with them for 6 months, but anyway, that's what they said. 75% commute data to governments, 38% commute data to care recipients or family, which I think is a really important finding. Like, why are you not saying to family members and the community that you're serving what's happening? That's, again, another environmental kind of thing. So tracking performance across department service is really great. People value it. That's what people want. So, you know, we're seeing that the sector is wanting to be engaged. People and culture. Data literacy training is not offered or only offered to specific staff. Huge gap. The aged care workforce in Australia is not equipped with data literacy skills, yet they're the people collecting and reporting the data. So that's a huge gap, especially when 2/3 of staff use data in decision-making frequently, and 63% have implemented a culture of continuous care data. Again, that result does not align with what we found over the 6 months of working with them. It's quite a negative culture. It's a punitive culture, and they're very scared of speaking up if something is perceived as wrong. In their future state, they want data quality, so data literacy skills to support consistent processes and high quality data, and they want integration, which I think, you know, is what your team here and the population is really interested in. So without making data improvements to data quality, it limits downstream transformations and reporting abilities. They really want to prioritise data quality and incorporating triangulation, so looking at different data sources to inform what they report, and quality of care improvement across organisations. I must say, this is a community in Australia that is extremely invested and very much cares about the outcomes of people using aged care services. So the 8 aged care providers that came to us are extremely invested in that, and were willing, when we curated a safe space for them, they were willing to open up and talk about these issues. So just my key messaging is, the Australian aged care sector recognises the need for improved data and digital maturity and is ready to engage, but it has to be a very supportive environment. They understand quality data in means trustworthy results. Assessing digital data maturity alongside data discovery really helped us to understand a realistic appraisal, because what they reported in the survey was not necessarily the reality of the situation as we move through the 6-month project. Data literacy is a core skill set for aged care providers, and education is currently lacking. We went with the message of data is everyone's business. Not everyone has to be a data analyst or everything, but from the beginning to the end, people have to understand their role in how to collect and report quality data. And if that's not understood across the whole breadth of the team, one little chink in that armour can mean your whole reporting system is out and you're investing money in areas that actually don't need to be invested. You must provide a safe space for aged care providers to reveal their data concerns. And one of our aged care providers came up with this and said, yes, I've learned to be curious and not furious. So when I see data that looks like we're doing a bad job, she's like, no, I'm curious now, I'm not furious. And I think these are really important messages that we need to get across in a sector that has been, especially in Australia, very heavily legislated, very heavily monitored after the Royal Commission. And it's almost like people are looking for ways to punish, but the data can be used in a really positive way. And that's the culture that we're trying to create and generate with this project, and then spread the news across the aged care sector. So thank you.
Thank you, Jody. Thank you very much for your presentation and a lot of information about different types of data. So now we are moving to the third use case from Finland. Here we have 2 speakers. We have Sirpa Irene Impinen from the city of Helsinki and Kari Mikkonen from Sentinaui. So please, Sirpa, if you can start, and then Kari.
Let's see if the presentation goes on, and very happy to be here today. I only have 1 slide, and I promise to be fast because we really want to hear what Kari has to say. But I'll tell you a little bit of why we have this picture of this tuikku here with me, because I used to work as a manager in elderly care centers in Helsinki area, and Helsinki is currently producing a lot of services for elderly people, and the population in the Helsinki area is 700,000, closing in soon. So we do need to remember the users. I think my main point is that there are people that we give services to, and the digitalization is about enabling safe processes and safe, high-quality care. And we do that partly with assessment, but the story behind with Tuikku here is that she wanted to celebrate her 100-year-old birthday party with Scandinavian hunks, and we made it possible. It was a shared event that represented something that she wished as a service for herself, and we made it possible. And I think it is very important that we recognize that there are still, even if we get older, even if we need services, we still have our own hopes and dreams that we would like to get to. And so why and how do we assess the older adults in Finland is with this resident assessment instrument that gives good point of view of data producing, like we heard before. So we produce a lot of data on how the people's functional abilities are developing during the aging process. And from Tuiku's point of view, I think her abilities were a lot better after the event from dancing youngsters. And I think that's my 3 minutes for today. And I give the presentation turn for Kari. And I can share the link for the news that she ended up into in Finland. So you can have a look at how the video shows on from the event that we arranged.
Hello everybody. My name is Kari Mikkonen and I work as a CAA for Finnish SME called Sentina. We have been pioneering research-based digital services that enhance the quality of elderly care for over 25 years now. And today I will tell you a story that can be an example of Finnish care. Sentina is a small company, as I said, and we have been working with the digital services that originates from research-based development that began already in the 98, and the market entry took place in 1999. So over 25 years of experience, and today there is something like 300 facilities that are using our services. We employ a small, highly skilled team of experts, and we also have a broad surrounding network, so we need to have the knowledge to do all these things. And altogether we have a long and extensive experience in developing well-being and rehabilitation, and of course these technical platforms for implementing all this in the everyday care. And we have also been working quite a long time with the researchers, and our platform is frequently used as a research platform, I would say. Our impact for organizations is that we enable smarter care through digital platform, and I think we enable the work that is expected to be done, but even there is not always necessary structures or capabilities in every place. And for staff, we enable ease and joy. I mean, people come to care to do good, and we make it possible even in challenging times. So even if there is some crisis or something, they still can have a platform supporting them to give the good care for elderly. And of course, for elderly, for clients, it is more meaningful communal daily life with interesting things to do. Life should be meaningful. It should be fun. It should contain the things that you are used to having in your life. And in Finland, the well-established and recognized model for daily activities has emerged during these years, and it contains time orientation, it contains games, reminiscence, physical exercise, cultural care, and in Finland especially, I think we have to embrace the nature care also. So this is kind of the setup that we have found out here. And at the core of the good care, there lies kind of appropriate balance of all these pieces. And of course, elderly think that they need to feel like they're part of something, and they must have a sense of being heard. And they want to still have some self-determination of doing things. And through years of development, our method has evolved into a structured approach that consistently enables high quality care, regardless of the actual caregiver's competence, because it varies quite a lot often. And this expertise and know-how we have also been transferring to our newer service that we have been developed. And originally in 1999, we started this development by a company called Audio Riders, where I also started my career. And our service originally was highly technical, engineer-driven platform. It was powerful, but it was quite demanding in terms of the skills and tools required to use it. And of course, that is as technical persons, we like to do it, very engineer-driven. But the first version that were Windows-based closed internet solutions were too difficult to use, and the development moved toward the embedded electronics, and ultimately we learned that the device independence is a decisive advantage, that you have to be able to use these platforms and these methods with the devices you actually have there. And over time, we gained some deeper understanding of customer needs and the varying digital readiness of the different actors in the field. And we shifted towards solutions that were easier to adopt and more widely accessible. And ultimately, this resulted in a SaaS-based service usable on any device with very low threshold and with actually no knowledge at all. Whoever could actually try to using these. We have different services that we offer today. Sävelsirkku, also called in many projects sound vitamins. It was originally built on scientific understanding of cognitive, social, psychological well-being, and now it translates the needs of the field and also the academic knowledge into structure, human-centered methods used in everyday elderly care. And 23, we decided to take this further, and we developed a service called Näyttämö, which is kind of developed to extend from Sävelsirkku, also evidence-based, also same contents as I mentioned, culture and so on, music and so on, but it is the kind of the using method is different. It is now screen-based use, so we are actually looking at the screen, while Sävelsirkku grounded in the idea of allowing images to form on the mind's inner screen. You know, when you're listening, you can get the pictures in your head, but when you're looking at the screen, it's a little bit different approach there. So now the Näyttämö complements this approach, and it is even more or lower threshold for caregivers to try to organize something nice or daily dose of joy in the care. And all this has led to the thought that we need to also sell these products to other countries, and now we are working in the Silver Moments project, which is funded by European Union, and we have created a Silver Stund called or named service that is actually in Sweden now, and it is AI-based, and there's a great potential for other countries also. So I think the main thing that we have learned during these years is that we have shifted from content to impact. That we at the beginning we started collecting all the content that could be used in the for example the reminiscence sessions, and then we focused that okay, we have to create a method that kind of sneaks all these parts into the daily care. And there is also a wide spectrum of needs that can be found from the daily care. And there is caregivers who kind of aim high and some aim a little bit lower. And the technical platform must support all of this. We learned that the content is not enough. A method is, and a structure are essential. So we have created a daily model for diverse high-quality activity planning that kind of considers each older person's needs, strengths, and interests. And we have created a daily model that is easy to adopt in the care. This is an example when we have been in other project that we are turning the benefits of music into structured care. As we all know, that music has a magical effects. It activates multiple brain regions and so on. It improves mood and reduces anxiety and so on. But the big thing is that we have created a method for musical will that was developed in project, and we have created a structured method to record and apply it to. And this musical will is a great example of how each elder person's favorite music can still be used as a part of the care. The second example is about the resident assessment instrument that we are using in Finland. Is a mandatory regulated assessment practice here, and it kind of feels that sometimes the assessments are done because we have to do assessments, and we have thought always that if you do assessments, it should somehow be done to benefit the care of the elderly people. So there's an example of when nurses are planning a group activity, and their measurement ADLH is giving a certain information, and this measurement can be translated so that these first persons, residents 1 to 3, their goal is to improve functional capability or ability, and the one person is a bit or her state is more difficult, so the main goal must be to maintain functionality, so they cannot be in the same group activity. So I think the structured methods guide the right activity for right person at the right time. And there is our website, and if we share this PowerPoint, there's also a video where you can see a little bit more. Thank you.
Thank you very much, Kari and Sirpa, for the presentation, to see something that is really implemented at the moment. So we have some questions for the audience, but we will leave at the end. And we are moving to the panelists now. So I would like just to share my screen and introduce you the panelists, and then we can start the discussion. Okay, so first of all, I would like to introduce the two people from Laurel project. So Giulia Lanfredi from Eurocarers and Annie Hendry from IFIC. So Giulia, if you want, please to introduce yourself, and please feel free also to comment about the presentations that you have seen.
Mm-hmm. So I can already proceed with my intervention for
yes,
today?
present
Or just
yourself, and
briefly?
then we will have the discussion. Yes.
Okay. So hi everyone, my name is Giulia Lanfredi. I'm from Eurocarers. As Sara said, my organization is also part of the Laurel Consortium, and my organization works with and for informal carers. We represent a network of national level organizations working on informal care with informal carers. Some of our members are from an academic background, some are more grassroots carers organizations. So this is the perspective that I will bring today to the panel.
Thank you very much, Giulia. Anne Hendry, honorary professor from the University of West of Scotland.
Yes, thank you very much. It's a pleasure to join you. And I'm also a partner with the Laurel Consortium through the International Foundation for Integrated Care. I lead the country hub for the foundation in Scotland through my university work there. And I'm a geriatrician, so bring that geriatric medical lens to the work. And I convene an international special interest group on ageing and frailty. And I know I recognise people on the call today who participate in our webinars on similar topics. So great to be with you today.
Thank you very much, Anne. So now we move to the ComfortEdge project. So we have Razvan Jon Trasko, medical doctor from Anaslam International Foundation.
So first, let me start by introducing the organization I represent today. Anaslam International Foundation stands as a cornerstone of geriatric and longevity research in Europe, in close connection with transnational networks like the European Alzheimer's Disease Consortium and several cost actions. Our approach to healthy aging challenged the 20th century stereotype of aging as an inevitable decline, and we tried to prove and successfully help seniors in leading active, meaningful lives. As for myself, I am defined by a dual role as a clinician, a family physician with a 20-year clinical experience, and a researcher bridging medical expertise with digital health innovation in an attempt to provide personalized, evidence-based support for older adults.
Thank you very much, Razvan. And we have now Rosa Almeida, and the project manager from the Intras Foundation.
Yes, good morning. So just to contextualize, I'm a gerontologist. This is my background base. And I'm coordinating European projects in Intras Foundation. Well, it's inside our organization, it's a kind of hybrid management framework between the Intras Foundation, our SME, and our Living Lab as well. So I have the different roles, but well connected. So just to contextualize also my organization, Intras Foundation, it's a key provider of social health and educational services in the Castilian region in Spain. So we work very closely with the communities, with a strong focus on participation and engagement. And for this reason we started Mind Lab. This is a living lab that combines territorial innovation with scientific and technological research. It is, as I said, closely connected to real social and healthcare services and is operating since 2013 at the intersection of social care, healthcare, technology, particularly in the areas of dementia, frailty, and home-based care. So in ComfortEdge, we are leading some tasks. One of the tasks I may mention today is about the development of advanced social learning strategies to improve the acceptance of digital tools among older adults, caregivers, and professionals. So just to finalize, very often our role in projects and also in collaborations with the public, private, and people partnerships is to translate exactly what today's presentation have highlighted, from vision to data to everyday life.
Thank you very much, Rosa. So that's great. Now we have all the panelists. We have also the speakers with us, and we have Luc.
Thank you, Sarah. So we will be interacting, both Sarah and myself, with you all. But I would just like to start a discussion with our panelists with trying to summarize 3 key messages that we got. The first one for Marco was very important because he's telling us basically we need to look at the geography of aging in a clever way, in a smart way. We need to redesign the way we look at the geography and the mobilization factors, mobilizing all the data that we need, and to have a new way to look at it, and to be sure that we use all the resources available in the system, whatever they are. The second message was clearly that we need to consolidate knowledge and to have a way to have this information processed so that we learn quickly. And we, that was also one message from Jody, is that we need to be more and more capable to use predictive analysis in order to better frame our interventions. We learned that 50% of the people in Australia were already using predictive analysis in designing the intervention. So that's a very important second message. And the third one that we heard from the very interesting presentation from Finland is that basically we have tools which can be extremely agile and which are not anymore designed for specific segments or specific carriers. but which can be completely adapted to specific situation. And that's exactly, I think, the point here about integrating social and clinical care together. It goes beyond that. It's basically adapting to environments and having the tools which actually can accommodate any kind of context. So I would like maybe our panelists to reflect on those points and any other point that they would have spotted by themselves. So what is your point? What is your reaction to those three key messages?
Yeah, there were lots of things that I heard during the three presentations that really struck me, because they're topics that have come up a lot in my work so far. I think one of the things that struck me the most was something that was mentioned by Marco, if I'm not mistaken, which is the importance of early intervention and making the connection with carers at an early stage, not when carers are in a critical situation and they are not able to be carers anymore. When the acute situation presents itself, there is a caregiver burden, there is strain. This situation puts both the carer and the person in need of care in a difficult position. The quality of care that is being provided is not ideal. And this can also lead to speeding up the process of hospitalization, of institutionalization. So intervening early in a preventative manner is really crucial. And in order to be able to do this, it's important to already have the connection with carers built into the infrastructure of integrated long-term care. If we don't know who the carers are, if we do not have a way to connect with them from the very beginning of their care journey, it's going to be difficult, and it's going to be difficult for everyone to do so when the situation is critical, when there is a high level of stress. So this is a point that is really important. And one other thing that I wanted to mention that I think is connected to my work a bit is the fact that often when these connections are not present, the work of making the links and becoming the connection falls on the shoulders of carers, because carers are often the people that are keeping track of medical appointments. They are making the connection physically between different services and different providers. They are the ones that are storing documentation when there is not a digital tool that is able to connect all the different documentation. So in order to make sure that there is not strain on the carer and there is not low quality of care provided to the person in need of care, it is important to have all these connections already built in. And I think some of the presentations given today showed good examples of how this is already being implemented. Now, of course, one other thing that was mentioned is the fact that sometimes interventions are not able to reach all the people that need so. And I think I also saw a question in the chat asking about this, about what is the level of the reach in practice of some of the interventions here today. Obviously, the financial aspect is important. So these are just a few points. I don't want to take too much time now.
Thank you very much, Julia. Very useful. And don't you think where you are in a position where you're actually involved in the strategic planning? So don't you think we need to look at the way we screen people? Basically, so that we can indeed design interventions in different way, and again, mobilizing the right actors and collecting data directly from the people in a different way. Because today we only rely on specific healthcare provider. We know that they have not a lot of time, and we know that screening is performed in a very ad hoc way. So don't you see that facing aging and the risk of dementia and others, we need to try to change the way we do that? And how should we do it? What is your perspective to that?
Yeah, I guess that speaks to moving towards a population health approach, and actually understanding that to really impact on aged care, we need to start much earlier in the life cycle. People who develop frailty and multimorbidity in later life are people with risk factors in midlife. So the earlier we are involved in a population health approach, the better. So I think screening is hugely important, but it really has to be population-based screening, and then develop a more segmented approach to target some of your more detailed assessment. And what struck me this morning about the conversation around the use of the RAI is moving from a focus on collecting data, particularly shifting from biomedical data towards that wider biopsychosocial information that tells you about what outcomes matter to the individual. You know, to really focus on personalising interventions that really generate well-being and enable participation to bring that meaning and purpose to life. So I think we are, you know, that phrase, we're on a journey to shift our screening and assessment towards a much more outcomes-based personalisation approach, both for the individual receiving care and for the caregiver, the family caregiver, the unpaid carer. I was very heartened to hear about the inclusion of culture and nature in the supports for well-being. I think in my experience in Scotland and, you know, UK and much of international experience, physical activity and cognitive stimulation are very widely now deployed and accessible in long-term care settings, but there's less focus, I think, on the access to nature and cultural activities. And it's great that the European Commission actually this year has a real focus on the role and contribution of culture to self-management support and well-being support. And that links with work on social prescribing, which is something that is really taking quite a lot of attention and energy and enthusiasm. Just final comment, Jodie's mention of the level of investment of the workforce in this sector is massive. That absolutely resonates with me, Jodie. People go to their work to make a difference. They want to do good. It's our responsibility collectively to make the right thing, the easy thing to do for them. And that's, again, something that we're very focused on in my context, where we're trying to work together to move from a culture of assurance and performance to a culture of continuous quality improvement.
Yeah, thank you very much, Anna. Jodie, you wanted to react quickly to what Anne said?
I just want to comment on what Anne said, is that we have this enormous expectation on this workforce. It's an extremely difficult place to work in terms of workload and resident needs, and yet we still, you know, we flow over this blanket and go, oh, now you're going to collect all this data and you're supposed to do this. And we're not giving them any structured support to do that. And yet governments are acting on the data that is coming out of it. And the workforce in Australia is extremely dedicated to doing really great things for older people. And we just want to support them. So however we can support them, however we can do that nationally or internationally or any way we can, it's so important. So sorry, I'm just reiterating what you said, but.
And look, if I can just add to that, yes, we need to support them nationally and internationally, but all improvement is local. So we need to make sure that the support is local. And that's been a really powerful change that we've introduced in Scotland with something called the Partners for Integration Network, where the umbrella organisation Scottish Care has local support working at a local level with aged care providers. And that is spanning the providers and the commissioners. So really trying to make sure that there's almost an independent advocacy voice there that is connecting the commissioners of care and the providers of care.
Yeah, and I think it's really important.
Yeah, sorry, Jodie, but I want to give really the word to everybody. So sorry, but Yeah, thank you. So, Rajva, in Romania, Anaslan is a very respected institution because you really have now a very rich experience already in interacting with our target population and trying to be as innovative as possible. So we learned here that culture, nature, that music and altogether joy needs to be part of the way we actually interact with the people and to support prevention. So what is your experience? What can you share with us that really works in order to enhance the right behaviors and the right interaction between the different actors which need to help people?
So first of all, it is my belief that healthcare for older adults can no longer be a series of, let's say, disconnected episodes. It must be some sort of an ecosystem joining all stakeholders, including medical experts, clinicians, so formal caregivers, informal caregivers, people working with social care, technical people. Everybody should work together and preferably on a single platform, if that's possible. Then if you go to the individual level, you have to approach every individual as a whole. That means physical data, mental data, social data, so integrate, as others previously said, and I particularly liked Impinen's motto, let's remember the users. Let's remember the people we care for, and let's remember their carers. If we talk about the data, I think it's very important to view data, let's say, as a right of every citizen. And every people being cared for is a citizen, every carer is a citizen, so data should not be used just for science only. I would also like to touch base on prevention and on the power of modifiable risk factors, particularly in dementia. And we should be the ones to drive public health policies from a focused funding on late-stage treatment to midlife and early life risk reduction, because it's never too early and never too late. And risk reduction is a life course journey, and it starts from very young ages. I would also like to conclude, and this was kind of touched by Kari with the daily dose of joy, the mantra which we all loved, that we should shift AI to a goal of caring and not controlling or fact-checking. And of course, we have to use the AI in a responsible and explainable way. And there's this topic that nobody really touched base on, which is the intrinsic capacity. We must stop measuring health solely by the absence of disease, because, and I'm sure Annie can confirm this, success in geriatric care can be measured by a person's ability to move, think, and interact with their world. And this was touched tangentially by Impinen. And not the least, I think we should consider the informal caregivers as basically the backbone of any healthcare system. And I think that any integrated model that does not provide robust support for them is designed to fail at some point, because they can partially cover up by solving the shortage of geriatric specialists and nurses. They can help in addressing modifiable risk factors. They can help even with cost cutting, and improving their quality of life would implicitly improve the quality of life for patients.
Thank you, Rajvan. No, we heard that there is so much we can do if we have the right information and we have it on the right time. So that's a lot of challenges. So we heard about digital literacy. But at the end of the day, we know that we need the citizens and the patient themselves, and we need to find ways for them to provide the data that will help them and will help the community and the systems to get better organized. So Rosa, in interest, you are really familiar with the concept of social learning, because you've been trying to work on how to bring the intelligence of communities. And communities may be the new actor, which needs to come as the link between the professionals and be them on the social care or the clinical level. So what would be your key messages? Because you've been working on that since a decade or so now.
Yes, after a small pause, because I was not working in the last 8 months, but before this event, I had a meeting with my team to just refresh what we were doing in the project and so on. But in general, so considering the presentations and the topic you mentioned, and specifically also connecting with what Judy mentioned that data already exists, but there are a lot of challenges on the quality of data, also for integration, and in the capacity and culture, this is really important, needed to use it meaningfully by different actors and related sectors for the aged care. So from our experience, I would add that social services are not only care providers. They are also major data producers and users. So they often hold essential information about daily functioning, social isolation, and informal care. So the challenge here is not only on interoperability, but mainly on governance. So we already know who use data, when, and for what purpose. But from our experience, technology only supports the integration of preventative and care services when it strengthens relationships. So this is what was one of the common views of the different participants here. So also connected with this, important to say that technology is most effective when it creates meaning, not just efficiency. So this is why we are not just, co-designing, co-creating with people, but also working with different frameworks, for example, value-sensitive design. So how we can focus on the values, not just the preferences, but not the value of new technology and services, but with the values of people and how they value the different interventions and so on. So we have different experience in the implementation in region of these methods, practices of engaging people, and one of those is in Comfort Age, yes, on the advanced social learning strategies. So we have worked with since the beginning of the project, combining scoping reviews, participatory workshops, nudging approaches, and living lab experimentation to improve the acceptance of digital tools among older adults, caregivers, and professionals. So I just want to, I have a lot of points here that I took some notes from the presentations that I want to highlight, but just to finalize, I think it's also important here, and because I'm working in the management committee of Enol, so living labs here are key actors, I think, because they create spaces where health actors, social care professionals, caregivers, and people living with dementia and so on can co-design, co-learn, and gradually integrate technology into everyday life. So
thank you very much, Lorena. Just while Sarah is checking the last questions in the chat to be sure that they've been answered at some point, there's just one, just to put on the table something which one of our Comfortage colleagues has recently said from the University of Manchester. Is basically they work in communities, in places where people gather, and to discuss and so on. And basically, they are trying just to have this tool which just predict how much they are confronted with risks, basically, and to see how they say. And they were just saying the way that it was discussed in the community with joy, with light, in a very light way, has changed completely the way people look at it. They are not anymore afraid to discover risk. They discuss it together. So indeed, there is here an approach which I think is extremely promising. We can't go much further on this topic today, but I think your experience, Rosa, is really, really, really important. Sarah, do we have any questions unanswered in the chat?
I will go through some questions. Meanwhile, we will share some polls with the audience. My colleague Maria will launch the polls, and please, if you can answer to these questions, they are in line with what we have discussed, and we can then probably comment them. Meanwhile, there is a question which was not answered and is directed to Marco Albertini. If you can explain what you meant by family by default approach.
Yeah. So I collected two questions, I guess, and then there is the other one if I got it right. So families by default is a term we use especially in the study between family and social policy that was suggested early on by Leitner and then by Chiara Saraceno in articles on European societies, European Journal of European Social Policy and Demographic Research, if I remember correctly. And the idea is that in some countries, there are many countries that, especially in Southern Europe, but also Germany and so on, that attribute a big role to the family in providing support, okay, like the forefront of support provision. But some countries support families in doing that, some others don't or do very little. And so that is family by default, by the absence of alternatives, let's say. So I hope I answered in a sufficient, clear way. Shall I move to the next question?
Yes, if you have, yes,
okay.
Please.
Yeah, so Diane, I hope I pronounce it correctly, White House asked me, okay, what about the 42 approach and what you have done differently? So I must say first that unfortunately we were even binded not to, sorry, there are, can you hear noise or you can, okay, good. Because there are external noise. But anyway, what we were binded to have only pilot projects. We could not develop solutions that are already market ready. We were forbidden to do that by the project itself. So that is one, that's part of the answer, okay? But basically, just to give you some numbers, in the mapping we have done for all municipalities in Italy, and with only data that is available also to municipalities. We didn't use data that is not available to the general, mayor or whatever. Then we have collected this mapping across social classes and education and so on. And this is going to be a panel study of caregivers, but only for one region, which is Emilia-Romagna. Is a big region, not so big, it's about 5 million people in the north part of Italy. And we collected survey data from 3,600 people for the sensors. And that's, I guess, the topic here. monitoring caregivers. We just have 90, but why is that? Because we are giving sensors to them. But the idea was to develop a web app, which is, this web app is already there and is integrating, you know, pop-up questionnaires. So people would see a questionnaire popping up, okay, each 6 months that has the social dimensions. And then for 1 week, all the week, 24 hours a day, we have sensors. But that is not sustainable. We want that people can interact with this app with whatever sensor they have. Many of us has, I don't know, you know, a smartwatch, okay? So it's not sustainable to think that the health or the social care system is gonna provide this kind of sensor that we are using. By the way, there are huge issues with privacy laws and healthcare related laws. So we were asked by our bioethical committee to use medical level sensors. What happened? That 1 out of 7 of the 90 people we involved so far, we discovered they have not diagnosed serious health related problems. I mean, problems they need to go to a cardiologist very soon, okay? So once we use these sensors, we need a doctor to go through this data. We need to let them know, and the health sector will, in the first place, be against that, because otherwise they will be flooded by people asking for healthcare. But in fact, what we are seeing is that we have 1 out of 7 caregivers that has no idea that they have a major health issue, okay? But also to connect with what Julia was saying, I think our best finding, and I think we can improve that also with a web app, not sensors needed, if we can connect the informal caregivers, is that you would never think that not going to a cinema is a problem, is a health-related risk. Not going to a club is not a health-related risk. And then you sum up all these things, and this is called social withdrawal. And that we know that in a few months is gonna be depression, sleep problems, and so on and so forth. Do we need to wait for having sensor data to tell people that they are going the wrong direction? I don't think so. About the engagement, we can engage caregivers, and Julia, what we realize that caregivers are craving for a unique data source and source of information about which services are there, which NGOs are there. In my municipality, not in Italy, don't give me an email, don't give me, I mean, if you, a general email, give me the phone number of people in this municipality. That is going to be a very challenging task because that requires a lot of work, but that is what, and then you get people getting in. They are not happy to give you the data unless you give something back, but something back is more related sometimes with the information than with their health data. Sorry, other numbers? The planning with the drones, that was applied to 3 municipalities. In one of them, they have already moved the services, the pharmacy and the nursing home, depending on this planning. And about the biographies, we started 6 months ago. We have collected around 250 biographies so far. Okay. So these are the numbers. So I hope, I don't know if there were some other questions around.
Okay, thank you very much. Probably just one last question from Mark. That I'm so sorry that about social data which are not well defined, shareable and interoperable like health data. Who want to take this last question?
I can take, but I don't want to take all the time. So, as you want.
Unfortunately,
Yes, Marco.
Sarah, unfortunately,
Yeah.
I would have loved to have
Yeah.
Jodie because she has been working on data, mentioning
Okay.
data, but unfortunately, she left. So the question is more for her then. But thank you, Sirpa, for having just reminded me that it's not only TIC Salud, but it's also THL. It's also not only Catalonia, but also Finland, who are working on making social data interoperable. Thank you.
But I think one of the key messages here is basically, indeed, just what Marco just told us about how we can not only bet on one way to collect data, but to use multiple channels. That including this, clearly the carer's perspective is really important, so that we have some knowledge. For social data themselves, a lot of data can be provided by me and you, basically, if we have an interest to do so. If of course that we see the advantage and the added value to do it, and indeed we don't necessarily need census to do that. And I would say that social data have, in my perspective, a high potential because they are probably easier to structure and to code, especially with the prospective use of AI in the future to use them. So I see personally the possibility to have a massive collection of data, of course, GDPR compliant, which can certainly help us to model the services in a different way and to access available services also in a different way. And also include the perspective that I heard, where indeed medicine can replace partially medicine, music can replace medicines, and culture and nature, and all those elements which are important elements to diminish risk factors or to basically deal with health issues can also be taken into consideration. And I think, Sarah, we have more or less used all the time available for this webinar.
We can. Yes, thank you very much. It has been really a great pleasure to have you all here.